months, about a year. But, brilliant, always been brilliant. A child of this church, of this ministry, grew up here, has probably one of the best 10 million kilowatt smiles you'll ever see. And we're so excited that she's going to be here with us today to help educate us about breast cancer awareness. Of course, October is breast cancer awareness month, something that's near and dear to our family personally, especially mine, with my mom being healed from breast cancer, being a breast cancer survivor. Yeah, you can thank God for that. And so at this time, I don't think I have to put any more on it. Please welcome Miss Kirsten Bradley, Dr. Kirsten Bradley, with our presentation this evening.
Thank you, everyone. You can have a seat. Good evening. I'm going to stand for a little bit and talk. I think most everybody knows me, but I will start with a brief introduction. I'm Dr. Kirsten Bradley. You might know me, but you probably don't know my exact professional journey, so I'm going to give you quick notes. Actually, my education started right here in this room. This is where I went to daycare, and the majority of my early education was at Calvary Christian Academy. Up until the 10th grade, where there was some restructuring of the school, and I ended up graduating from Youngstown High in 2001. From there, I went on to pursue my undergrad studies at the University of Pittsburgh, and I graduated from there in 2004. During that time, I graduated a little early, and I ended up staying there. And an interesting fact about me is that I spent some time putting together a creature like this. This is a prehistoric rhinoceros. So after my undergraduate, I spent time training at the Carnegie Science Museum, where I was put in a dungeon and given a bunch of fossils. And this is one of the structures that I worked on completing, which ended up being swapped with a museum in China. So that's a little bit interesting fact about me. Not a lot of people know that. So after that, I ended up graduating and going off to medical school, where I spent the next 10 years at the University of Cincinnati Medical School. I graduated from med school in 2009, and then I did my residency training for the next 5 years for radiology and a fellowship in breast imaging. So my specialty is radiologist, and my subspecialty is breast imaging radiologist. So that is what I do most of the day, Monday through Friday, 9 to 5. I work up women's breast cancer issues, breast problems, every biopsies. I look at all the breast imaging. And so that brought me here to Akron. I actually practice in Akron at Suma Health Systems. My group is called Akron Radiology Inc.
That has the message up about Switcher Studio. On the
so I don't want to keep
it's
you
got a
long.
message up about Switcher Studio.
We don't stay out late on school nights because we have work in early morning. So I'm going to be brief as I can, but I do want to touch on an important topic. It's such an important topic, and especially at this time of year, this breast cancer awareness really kicks in, and it brings a lot of women into the clinic, and a lot of lives are saved because of it. So I'm really thankful to be here for this invitation, and I'm hopeful that this talk will impact someone here in this room, if not you directly, a family member, as you spread the word about the knowledge that you gained here tonight. So, that being said, I'm going to let this.
I'm not picking it up for some reason.
Hopefully play.
I'm picking it up for some reason.
My name is Anita Harris. I am 38 years old. I was born in Chicago, and I'm currently living in New York City. I don't remember exactly the month, but I do remember in the shower, and I had felt a little lump, and I was like, what is this? And I can't be, I don't have a family history.
Let's try that again. Okay. I want to
It's
try
not
with the
playing
mic.
it here for some
I
reason. I don't
apologize
know.
that there might be some.
It's supposed to be bringing
My
it
name
in.
is Anita Harris. I am 38 So I was born in Chicago, and I'm currently living in New York City. I don't remember exactly the month, but I do remember the fact that I was in the shower, and I had felt a little lump, and I was like, what is this? And I just looked at the child, and I was like, no, it can't be. I don't have a family history of breast cancer. I never thought that it could happen to me. For my diagnosis, I'm doing really well with my job. I haven't had children yet. I haven't been married yet. Will I still be able to have children? All that changes when you have a breast cancer diagnosis. What scares me the most about being diagnosed with breast cancer is that moving forward, things won't be like it was before. It'll always be on my mind. It'll always be something that I think about. I don't feel as if though Black women are visually represented, and that's probably one reason why I felt as if though this is not a Black woman's disease. This is not something that Black women get. There are women who look like me, who are going through this, who are surviving.
Your audio level.
CSG Home Foundation has been a very important factor in my journey. I was able to learn so much about breast cancer, especially how it affects the Black community, the disparities amongst Black women. Join my fight and save lives.
Okay, so I'm going to show that video just to kind of touch on a few highlights and laughter tonight. And that is to talk to my Black women and men, because for so long the conversation did not address the disparities in health outcomes as it relates to breast cancer, particularly Black women. And so conversations like these are really important in order to help. So tonight's conversation is really going to focus on Black women and touch on Black men as well, who can also get breast cancer, even though it's much less common. So tonight's going to be a conversation. I am going to touch on the following topics. We're going to give some basic facts about mammograms and how we screen the breast. We're going to talk about risk factors, signs to look for, and anything we can do to reduce our risk factors. We're going to talk about symptoms we can look for on ourselves in addition to going to your doctor and having a regular checkup. We are also going to kind of go through what it's like to get a mammogram, because I know there's a lot of fear, and sometimes you hear all these stories, and sometimes that prevents women from going to get their screening. So we're going to kind of talk about what it's actually like and what you can expect for those of you who haven't been, or you may have a family member who's reluctant. Maybe you can help encourage them that it's not that bad. We are also going to talk about when you should start your screening, and we're going to discuss briefly about the guidelines that are out there now. And then again, we're going to finish up touching on Black women and why are we having worse outcomes, and we'll kind of go through some of that as well. And in the end, we'll wrap it up with some questions and a few cases. So, apart from skin cancer, breast cancer is the most common form of cancer affecting women in the U.S., and it's the most prevalent cancer of women in every nationality. In fact, 1 out of every 8 women will be diagnosed with breast cancer, which is about 12.5% in their lifetime. And 1 of those 39 women, 1 in 39 will die from breast cancer. For high-risk women, due to varying factors, that number increases even more, and it increases to 1 out of 5 women, or a 20% lifetime risk. Men, breast cancer is relatively rare, but it does happen. I have diagnosed breast cancer in men myself. The risk for you is about 1 in 833 men, or about 1%. Breast cancer is 70 times less common in Black men than Black women, but it's still higher than white men. And although rare, it's usually detected later, which can lead to worse outcomes, because obviously men aren't going to get their regular screening mammograms, but there are some things you can look out for yourself that we will get into as well. In 2022, it's expected that about 2,710 new cases of invasive breast cancer, which is a subset of breast cancer, doesn't include other forms of breast cancer, but the invasive breast cancer is about 2,710. And of those, 530 are expected to die by the end of the year. In men, BRCA1 and BRCA2 gene mutations, you may hear that. Some people call it BRCA as a short. But those are two genetic mutations that run in families, and we see oftentimes that is those men that are getting the breast cancers. And oftentimes they don't know they have that gene mutation.
The female breast is mostly made up of a collection of fat cells called adipose tissue. This tissue extends from the collarbone down to the underarm, and across to the middle of the rib cage. There are also areas called lobes, lobules, and milk ducts. A healthy female breast is made up of 12 to 20 sections called lobes. Each of these lobes is made up of many smaller lobules, the gland that produces milk in nursing women. Both the lobes and lobules are connected by milk ducts, which act as stems or tubes to carry the milk to the nipple. Also within the adipose tissue is a network of ligaments, fibrous connective tissue, nerves, lymph vessels, lymph nodes, and blood vessels. The lymph system, which is part of the immune system, is a network of lymph vessels and lymph nodes running throughout the entire body. Similar to how the blood circulatory system distributes elements throughout the body, the lymph system transports disease-fighting cells and fluids. Clusters of bean-shaped lymph nodes are fixed in areas throughout the lymph system. They act as filters by carrying abnormal cells away from healthy tissue.
So I did want to touch on the basic anatomy of your breast so that you kind of understand. As I move into the different types of breast cancer, we're going to talk about where they can develop and give you kind of the most common breast cancers that we do encounter. So now you have a basic understanding of the composition of your breast. So what is breast cancer? Breast cancer is basically an abnormal, uncontrolled proliferation of cells in your body. They are unchecked, and so they can lead to all sorts of problems and overwhelm your system. They will, like parasitic, siphon all your nutrients that are supposed to be going to other vital parts of your body. They will cause issues on the adjacent structures due to size. They will spread and affect other areas of your brain, but it basically starts as a single cell that begins to replicate out of control, and that can lead to, obviously, many deleterious effects. In the breast in particular, the two main areas where it can develop are in your milk ducts, as we saw, or in the lobules where the milk is formed. It can also occur less frequently in the tissues in between, in your connective tissues as well. The two most common types of breast cancer are ductal carcinoma and lobular carcinoma, with ductal being far more common. These two types of cancers can be either invasive or non-invasive. Non-invasive basically means that whichever structure the cancer cells developed in, so say you have a ductal cancer, that means that your cancer cells started in one of your milk ducts. As long as it is contained within that milk duct, it's called a non-invasive ductal carcinoma, or you might hear DCIS, ductal carcinoma in situ. In situ meaning contained. So it is still contained. When it becomes invasive is when it spreads beyond its origin. So once it breaks through those milk ducts, then we call it invasive ductal carcinoma. And it's the same with lobular. If the cancer starts within the lobules and it stays within the lobules, then we call it in situ. And those are stage zeros. Once they spread beyond their original site, then we start getting into greater stages depending on how far it's spread in your body. And then this will become important as we talk about why early screening is so important. So again, this is just a diagram showing you the different parts of the breast and where our cancers can form. So here we see that this is a breast looking at it from the side. This is a nipple. So imagine that the woman's head would be here, her feet are down here, and this is her back. So you can see that we have this network of milk ducts that are leading all to the nipple. And at the end of these, you have these bulbous lobules, and this is where your milk is formed. You can see these red areas. This is giving you an example of the different types of cancerous cells. So this is a duct, and if you have some cells in here, you would have an invasive ductal cancer, because we can see these cells have now breached the wall of the duct. And the same here, this will be a lobular carcinoma because it's developing on one of the milk lobules and it's gone outside of the border, so it's now invasive. If it remains contained within that duct, then this is what we call DCIS, or stage 0, which is important because the earlier you catch it before it spreads, the easier it is to treat it and much higher is the survival rate. So what are some risk factors for breast cancer? There's two categories. There are the risk factors you cannot control, and there are the risk factors you can control. So risk factors you cannot control, the largest one by far is just being a woman. And there's nothing you can do about that, obviously. Well, depends who you ask now, but being a woman. Age is also another factor. As you get older, your cells lose some of the normal reparative functions, and that increases risk of cancer everywhere, including the breast. And then there's genetics and family history. We touched briefly on the BRCA1 and BRCA2 genes, but there are also other predispositions that may not necessarily be related to a gene mutation. So if you go to your doctor, they may start asking you, did your mom have cancer? Did your dad? And they'll go through all these questions to kind of get a sense of your risk factors, and that will determine the type of screening you need and if you should start screening earlier. The factors you can control, however, are a few of them. Weight. We know that obesity increases our risk for breast cancer, as well as the lack of exercise and being sedentary. Now, these are related, but they have their own separate benefits. And a lot of this is related to, and is believed, including alcohol, is because it causes excess estrogen. Fat in our bodies holds on to the hormone estrogen, and a lot of our breast cancers are fed by estrogen. So you might hear people talking about estrogen and progesterone when we talk about breast cancers, and that's a hormone, and breast cancers have a receptor to receive that hormone, and it feeds it. So if you have an estrogen or progesterone sensitive tumor, if you have excess estrogen in your body, it's going to feed those cells, which can lead to that cancer development. So that's why weight and exercise and living a healthy lifestyle is very important. So what should you be looking for? So obviously you should go to your doctor, get your regular checkups. They'll do a breast exam on you and check for lumps, skin changes. But you should always, I'm a big advocate for that. You are your best advocate. So knowing what your breasts look like, so that way you can catch the changes, because everyone's breast is going to look different. But you know what your breasts should look like and should feel like. So be touching on your breasts, be knowing what they feel like normally, so that when they are abnormal, you're the first person that's going to catch it. You should be, at least. So a new lump, obviously that's a big one. If you never felt it before, you're not sure, maybe not, call your doctor, go in for an exam. Swelling, the breast getting one breast getting bigger than the other breast. It doesn't have to be just a focal lump. There can be a diffuse process, so that's another thing to look for. Skin changes. We all know if you have just like a pimple or a bump and it goes away in a little while, but if you start noticing thickening, dimpling, color changes that don't have an explanation, like you hadn't fallen recently or got in a fight, so you shouldn't be having bruising or skin changes. Focal breast pain. This is lower risk, but it is something that we do look into, because believe it or not, most breast cancers are not painful. They are painless, hard lumps. Nipple retraction. Our nipple is very important. It's where all our ducts converge. So if you're seeing changes in your nipple, please let your doctor know. Changes could be the nipple is flattening. And flattened nipples is kind of a common thing, but if you notice that it's a new change for you, or maybe one nipple is flattening and the other is not, that's a cause for you to reach out to your doctor. If the nipple is changing color, if it's being pulled in, you definitely want to reach out to your doctor for an exam on that. The skin around the nipple, or the areola, the colored portion around your nipple, that's an important area to keep an eye on as well. Nipple discharge. A lot of women get nipple discharge. Most of it is benign. What we are more interested in is bloody nipple discharge. And sometimes you may not know until you see a spot in your bra or on your clothes or you feel wetness. Those are the times when we want you to bring that to our attention. So bloody nipple discharge that you just notice. A lot of women, they squeeze on their nipple and they can cause trauma. But if you're just seeing it on its own, then that's definitely a sign that you want to present to your doctor for. And also the underarm. Lumps in the underarm can be related to your breast, and most often are related to your breast. And so that's an important area as well to check. But again, most of the time, breast cancer has no symptoms at all, especially when it starts. So that's why screenings are so important. The goal is to catch it as early as possible, and that's what screening is for, early detection. You don't want to wait until you feel a lump. You don't want to wait until your skin is changing. You don't want to wait until you have back pain, because those are all signs that your cancer is now maybe spreading. And that treatment course and the outcomes now become a lot harder and worse ultimately. So again, early detection saves lives, and I can't restate that enough. You get better treatment options, and your mortality rates are substantially reduced. A lack of timely screening can often lead to delayed diagnosis and a bigger tumor burden at diagnosis, which complicates things. So what can you expect? Most of you, the women have probably had a mammogram, but this is what it'll be like, basically. You'll be in a room. You're going to get 4 basic pictures, typically 2 of each breast. So this is the right breast, the left breast, the right breast, the left breast. So we're going to get 2 different angles of each breast. You will get squoze. They do squeeze tight, and we do that for a reason. It's because any type of motion really changes how the quality of the study. So you will be in there, and it will be pretty snug, but it's not terrible. You can do it. So please don't let that prevent you from getting your mammogram. Most people just have a little bit of discomfort. When should you start your mammograms? So the American College of Radiologists and the American College of Surgeons recommend that you begin at age 40 if you're of average risk. If you are of high risk, then that will start sooner, and you'll be directed by your physician when you can start. And women with higher risk will also qualify for some supplemental screenings, such as breast MRIs. So let's get into specifics of breast cancer in Black women. So unfortunately, Black women have a higher incidence of early breast cancer, being defined as before the age of 40, and are more likely to die from breast cancer. And recent studies have shown that although the new cases within Black and white women, the incidence is the same, Black women have a greater chance of getting early breast cancer before the age of 45. And there are other ethnic groups that also have an even better prognosis, and those will be the Asian Pacific Islanders. So Black women really have a big disparity as far as our outcomes. And then we're going to talk about why, what are some of the reasons that this could be occurring. So one is tumor biology and aggressiveness. We are a distinct ethnicity, and so there are some things we face that others do not. We are 2 times more likely to get more aggressive tumors, and those are called triple negative tumors, and that's just related to the hormone status. And it basically means that they're harder to treat. They can't use certain hormones and things like that to treat them because they're negative for those types of receptors. So we get more aggressive cancers. Also, studies have shown that pregnancy can increase your risk for more aggressive triple negative breast cancer. And in general, Black women tend to have more children at a younger age. Also, breastfeeding. Not a lot of women know that breastfeeding after pregnancy can lower your risk of getting a triple negative breast cancer. I don't know all the science behind it, but again, we tend to not do breastfeeding as often as our other Caucasian counterparts. So that is something to know, that breastfeeding is really good for us after we have babies. So there are other factors such as hormones and steroid growth factors that we have in our bodies that other ethnicities don't. And then there's the lifestyle factors that we touched on earlier, such as our weight. And we do tend to have higher rates of obesity than white women. And then there's healthcare access, which is a big one. There are issues like socioeconomic inequality. Black women are less likely to report barriers, and this one really, touches, a sore spot on me because, unfortunately, there is, whether we realize it or not, there's bias in healthcare, and I think it's just now coming to light that there is bias, and that studies have shown that when your doctor looks more like you, your outcomes are better. So I tell my family, I tell my friends, if you can find a doctor that looks like you, your outcomes will be better, and I do encourage it. So do keep that in mind. So things like that, your symptoms might not be taken as seriously. And I'm not saying everyone's racist, but there are just these ingrained, inherent biases that may not be recognized. So remember that you are your best advocate, okay? So don't let someone try to dismiss something that, is a real issue. Find another doctor, okay? There's fear of cost. That's another barrier. There's fear of the pain. There's avoidance of news, and this is a big one, and I see it in all races. People know there's something wrong, but they're not ready to deal with it. The problem is you will deal with it eventually, but it will be much harder to deal with. I've seen women walk in with literal masses almost growing out of their skin, been growing for a year or so, but there's this blockage, and I can't deal with this right now, I'm going to avoid it, and there's this mental block. Please do not do that, and I know some women are going through so many things. I see when my husband's dealing with cancer, I'm taking care of this person, especially women, because we are caregivers, and so you're worried about your children. I can't do this, I can't go through this because I got a husband, I have to take care of children, my mom is sick, but ultimately, you can't take care of anyone if you're not here. So women have to remember to stop and take time to take care of yourself, and then you can take care of everyone else. So I'm going to take a pause here. Again, the best protection is early detection. Are there any questions so far? Anything? Okay, that's fine. If not, we will move on. I'm going to go through a few cases so you can kind of see what a day in my life looks like just a little bit, and you can kind of see what are some of the things that we are looking for when you do come and get your mammograms. So this is case one. This is a 45-year-old female. She came in for an abnormal screening mammogram. When you have an abnormal screening mammogram, you're going to get a letter in the mail, and it's going to say you had an abnormality, you're going to need to come in, and we're going to do some additional imaging. These are the additional pictures. You can see this is the breast, and they're blown up, and we're doing a spot view of a particular area. You won't be able to see it, but these are microcalcifications or calcium deposits, and these are hidden in this breast. I've blown it up for you. These typically we would see in the earliest form of breast cancer, DCIS. It can usually start as an abnormal proliferation of calcium deposits in your breast. So we did go on to biopsy these, and this was ductal carcinoma in situ. Again, this was caught very early because she was doing screenings. A very small area, so that can typically be treated with surgery and some medicines. And just a lumpectomy. This is another case of a 54-year-old woman who came in for a screening mammogram. Now, unfortunately, she was a bit delayed for her screenings, so there's a little bit more going on here, but we can see the mass here and here. So this is the same, here. This is the same breast, the different views. So this is the mass here, and this is the mass here. You'll also note these round nodules, and these are lymph nodes, but they look a little bit too plump. So as we talked about the lymphatic system, it carries disease away from our body. It carries things away to be disposed of. That also causes issues because if there's cancer in the area that it's cleaning up, that cancer can then invade your lymph system. Because as those cancer cells are being drained away, cancer is a nasty thing. It will attach itself into these lymph nodes and then develop a new site of cancer. So that's what's going on here. So when she had this mammogram, we wanted to get a closer look of this area, so we will often take you to an ultrasound, and these are what ultrasounds look like. And here, if you follow my pointer, you'll see that there's this irregular dark mass. We call it hypoechoic. But this here was her tumor, and this was an invasive ductal carcinoma. This is a look of her lymph nodes. She had some plump abnormal lymph nodes, and she ended up having metastatic disease. So she had a primary cancer here, and her lymph nodes were in fact invaded with cancer. This is another case. This is, so we looked at calcium deposits or microcalcifications. We looked at what a mass might look like, and this is what we call distortion. So you don't see a focal mass per se, but the tissue just doesn't look quite right. It's not laying nice and smooth. It's kind of got these little lines going away from that, and we call that distortion, and that is a suspicious finding. And at ultrasound, she just had this really vague, dark area that raised concern. We ended up doing a biopsy on this. It was actually pretty large. It was about over 5 centimeters. And this came out to be invasive cancer. And due to its size, she's most likely going to have to take this whole breast off. Again, may not have had to do that had it been detected earlier with screening. And this is the same patient. So another study, advanced study we can do is a breast MRI. Breast MRIs they can be costly and they can take a long time and they produce thousands of images. This is just one composite image, just kind of give a summary of the breast, but this was what her breast looked like on the MRI. And you can see this is a normal looking breast. She did have one little spot here that we biopsied. But here we can see the main mass here, and then she has all these other little masses that were also cancer. So that breast ultimately had to come off. And this is our last case. I'm sorry, no, this is not our last case. One more case. This is showing an example of another mass biopsy. That's an invasive ductal carcinoma. And lastly, I wanted to show you a man. We do get men. This man came to our hospital system with a lump. And you can probably see the difference here. There's this white tissue here behind his nipple. And there was a mass here. This is what that mass looked like on ultrasound. And that ended up being an invasive ductal carcinoma. So that is really all I have to talk to you guys about tonight. I want to thank you all for coming. I know it's a school night. If there are any, this was actually me. I ran in a race for breast cancer awareness. We raised some money for Akron Children's Hospital. And so that's my partner, Jen. We're both breast imagers. So, yes.
My mother is undergoing radiation treatment right now for something. It started about 2 years ago. And my mom was always fairly open with me, even in class. And she wouldn't let me go in the restroom. Wouldn't let me in the bathroom with her about 2 years ago. And I didn't think anything of it. Because I usually go in and lotion her back. But then my sister mentioned something about on my mother's breast. Well, I barged in there and saw it. First it looked very small. Then by the time I got her to the doctor and had to fight, cut up, it had grown on the outside of her breast. It looked like a large truffle. So when they removed that, and that was a fight, and they removed part of her breast tissue, what came back was it was a carcinoma, it was cancer, but there was nothing in her breast. My mom is 90, so they weren't thinking anything about chemo. But we got to a good doctor, and he's doing the radiation treatment. She's getting all 30 of them. Next week, after next week, she has 10 more to go. Today was her 19th one. Today was 19, tomorrow will be 20. And they scanned all this. They did all this and her lower bowel. They found nothing anywhere. But they said if I had not have persisted, that cyst would have started growing inside. And again, yes, she's 90, but she's pretty healthy.
Right.
You see my chicken lady post on Facebook, Mom is a mess. But we have to be vigilant, especially with our older. My mom had not had a mammogram in almost 30 years, and I did not know that.
Okay. Well, that's awesome. She was blessed for sure that they were able to that it hadn't spread. Typically, once you see it start coming through the skin like that, then there's a high concern that it has spread within your body as well. So thank God that she did not have that story. But yeah, it's not uncommon for women to wait for a super late presentation. It's actually very sad. So, be diligent, talk to your family members, encourage them to get their regular screenings. It's not as bad as you think, I promise. Yes.
I have a question. I have a family member, a couple of months ago, so I guess. She had, one of her breasts, it was small. She said it started off small, and it had been going on for maybe a couple of months, and they got bigger. But it was really, really tender and sore to the touch. Well, they said it was calcium buildup or something like that. It's like, if that's all it is, is it a possibility that it can turn into something different, or is that something that's possible? Is that, just kind of understand it?
That's a tough question for me to answer without seeing her pictures and knowing. But yes, you can get, for various reasons, that calcium buildup. A lot of times it's due to some type of trauma that's happened in the breast, whether it be surgery, you could have an old car accident. The tissues in your breast can get traumatized and die. And when they die or necrose, one of the responses can be overproduction of calcium, and that can be painful. And so it is very probable that it could just be benign completely. The only way to know if it's at a higher risk of developing cancer will be a biopsy. But if it had a classically benign appearance, which we do have things that have classically benign appearances, we won't biopsy those. And so we can talk, if you have specifics, send me a picture. We can look at it and make sure she's okay. But that is possible. That is just something benign. Any other? Yes, Nick.
What's the likelihood of the cancer spreading to other parts of the body if it goes unchecked?
Unchecked, high. It depends. Cancer just doesn't stop on its own. I'll tell you that. Depending on how fast it spreads, depends on the tumor biology and the aggressiveness. And like we touched on earlier, Black women tend to get more aggressive breast cancers, and so there will be a shorter time period. Some women, it could take a year for that cancer to really grow and start affecting other women, and I've seen it happen in a mere 2 months, where you start out with something as a pea, and then you come back and you have now like a golf ball that's spread. I've seen cancers that are barely visible spread. They're so tiny that they spread, and they spread to your lymph nodes anyway. So sometimes there's no rhyme or reason that we can understand. But it's basically related to the aggressiveness of that tumor, how fast it will spread.
You kind of answered my question. You said that they recommend once a year.
Once a year. So you might hear conflicting stories. I'm completely against that. There are certain factions in medicine that don't do what I do. They don't see it every day like I do. That may say start at 50 every 2 years. Don't listen to that. So many more women would be dead based off of that. In fact, we are seeing cancer much, much earlier. I'm not surprised. I diagnosed breast cancer in the 30s almost weekly. I see it now in the 20s, at least, several times a year in 20s. The youngest I have seen, I think, was 22. Now, she would have probably a genetic mutation, but 50 is too late. They're more worried about numbers and money and expense, but not necessarily the person. So the recommendation is if you have normal risk, your average risk, start at 40 and get it every year, because the difference between a year and 2 years is drastic.
That was my reason for asking the question. You talked about some cancers are more aggressive than others, and they come in and within a month's time.
It could be spread.
So if you know you're at a high risk, should you be doing the exams more than once a year?
So when you go to your doctor, if you go to your gynecologist, you go to your family doctor, they should be asking you questions about your family history. And we have risk assessments at most offices now where they're going to ask you a series of questions or give you a survey. And depending on your answers, it's going to calculate a number for you. 20% and higher lifetime risk of breast cancer is that cutoff where you will qualify for earlier screening. There are also other factors like, say, your mother or any other first-degree relative had breast cancer. If your mother was 35 when she had breast cancer, then you should be starting screening 10 years prior to that. So there's a lot of things that can go into it. So we will start with the MRI. We typically don't do mammograms before age 30. But we do breast MRIs for younger women who have those issues, and that's one of our screening tools. And then once they hit 30, we'll start adding in a mammogram. And so they'll get screened very tightly. Every 6 months, they'll have either a mammogram or an MRI. So every 6 months, they're being checked so that we can catch that cancer as soon as it pops up.
Those cases that you said you get on a weekly basis,
Mm-hmm.
are the majority of those cases from the Black race, and do you think that our diet, the Black race, our diet is a major factor to why we're at such a high risk?
So really, the demographics that I see is based on where I live. So I do see, or where I practice, I do in general see more white patients just because of what's around that hospital. But I do see a relatively good number of black women, and of that, there is probably a higher incidence that they come in with later, larger, more advanced cancers with worse outcomes. And as far as the diet, yes, I definitely think diet plays a major role in all types of cancers, especially breast cancer. As that saying goes, you are what you eat. It's true. You are what you eat. That's how our body gains its nutrition. That's how our cells are formed. That's what we're feeding it with. And so not only the good things come with that, but the bad things come with that. So, it is cultural for us to eat in certain things, but in between those holidays, it's really important for us to be eating nutritious foods. Sorry. Sister Wilburn? Yes, I'm sorry.
Well, a person that had their breasts enlarged, and they've had, they said sometimes, I guess the nipples do flatten. Should they be concerned more about the fact that they may do that, or should they be concerned about cancer?
I wouldn't leave any changes to my own family member. I wouldn't want that responsibility to be on you. So there is a good chance it could be completely benign. I wouldn't take the chance. If you see changes in your nipple, I would present to the doctor, and you can tell them, what you think it might be from, but get a physical exam. Let someone touch on that area. Make sure the tissue is not firm. Make sure it's not pulling in. And so nipple changes, I definitely would get someone to look at it. Did that answer your question? Sorry.
Yes.
Okay.
When men have cancer in their breast, do they usually remove the breast, or do they?
Yes, it's usually it depends on how much breast tissue you have. A lot of men have a substantial amount of breast tissue. We see it a lot. So in those cases, they might just be able to cut out the area. But most men don't have nearly as much breast tissue as women, so that would require you to take the whole breast, because by the time you cut out the cancer, there's not much left, and it's not going to be aesthetically pleasing, and so they can just give you a nice new reconstructed chest. Yes, Rachel?
Should men screen too?
No. I'm coming, I'm sorry. The way men should screen is through self-exam and at the doctor. We don't do mammograms on men for screening. We only see men when you have a problem. Men who know that they're genetically predisposed, they will present to their doctor for regular screening. And now there are transgender men who are taking female hormones, and we will have a talk about whether we should be screening them, because they can get some of the same cancers based off those hormones as women can. So very rarely we will screen a man who is taking exogenous hormones. I'm sorry. Yes, Sister June.
Okay. So if you had a DCIS, how often should you be going to a mammogram?
So minimum of every year. Depends on where you are and how your surgeon likes to operate, but typically where I practice, after you have your definitive treatment, your surgery, we'll see you in the next 6 months to make sure you're healing properly and that we don't see any evidence of any residual disease. Very rarely we will come across a problem and that cancer either wasn't completely taken out, or the tissues around it have now developed cancer, and we'll have to address that. So initially you'll come back in 6 months, and then once you get the clear, you can resume just your regular annual screening, but being closely watched by your doctor so that if they can catch anything, you can come in sooner. But yeah, it's typically back to normal.
Just to finish, so you said men don't have mammograms?
Not for screening. They come in for a mammogram if they have a problem. Yeah, if they feel a lump or they're seeing some of those signs of skin changes or nipple changes or a pain, then we will do a mammogram on them.
Would you suggest that men do that physical exam on themselves?
Yeah, I suggest everyone know what your normal tissue, your normal breasts feel like and look like, so that way you know when there's a change. You're welcome.
You said that if men are genetically predisposed, they should get checked. Is that even if they have a woman family member who...
So that's usually how we find them. It's because their moms, their sisters, their aunts have breast cancer, and so then that raises red flags. And so usually one of those women will undergo genetic testing. And if they come back as having that gene mutation, that is when the rest of the family will get checked. And sometimes they don't all get checked. They just assume that all these women, this woman and that woman have it. You most likely have it too. Mom.
Okay, so question, I have a couple of them. The first question is, when you first started out, you said something about the collarbone down. So I didn't know that. So you can have something up in this area, like your chest area?
Yeah, so if you feel around your neck, you can feel this is the clavicle bone, these prominent bones.
Right.
That's usually the upper demarcation of where you can have breast tissue. So any area below there, you can have a breast cancer. So from there all the way down to your upper abdomen. And even in between, you can have knots in your cleavage area as well. I've diagnosed breast cancers in the cleavage. I've diagnosed them way up here under the clavicle. Most likely, one of the hot spots is going to be, we call it the upper outer quadrant, the tissue between your underarm and your nipple. That's a hot spot for where cancer likes to be, but it can be anywhere from your clavicle to your upper abdomen and all the way across.
Okay, and then my other question was, you're saying for us to know if we're predisposed, if we, are high risk for it, it should be, you find out from the doctors questioning you, is this your GYN doctor, OB doctor, or is it your doctor?
It's typically your OB-GYN. They cover breast health as well. And also your family doctor too. It depends. Not all of them are created equal, and not all of them are comfortable with handling breast care. So hopefully if they're not doing it, they're recommending that you go see the gynecologist to do it. You just want to make sure that someone at your annual exam is checking onto your breast health and that they understand the family history. If you are not sure, the next time you're there, talk to your doctor. If your mom or your aunt had this, bring it up. Say, I just want to know if I'm at increased risk and how can we find out.
Well, I was going to say, it sounds like we have to really take a hold to our own health, because I don't know that these doctors are asking the questions that they should be asking us now. It's almost like everything is a shortcut now, or they don't have time, or they're in.
Yeah, that's a big factor. Time.
You have to really go in asking and then demanding that they sit still long enough to answer what it is you're saying, because I don't know that it's happening for us. And I know people who have had struggles trying to get a doctor to pay attention to them. And now I'm like you, I'm trying to find all my doctors to look like me, because that's a head start.
Yeah,
They already know
absolutely.
us. So, it's just sounding sad to me, first of all, that
It is sad and it can be discouraging, but we also have to take control. There are things we can do, and it's difficult. It can be really difficult to find a doctor that looks like you, depending on where you live. This being one of those areas. It's difficult to find a black doctor here, especially if you need a specialist. It's going to be difficult. So don't let that stop you from going. Do go. But when that opportunity does arise where you can get a doctor that looks like you, studies have proven that your outcomes in general will be better. For, a lot of reasons, unfortunate reasons, but it is the case. So,
You said there was a higher incidence for African American women. Is it also true for
yes.
men?
Yes, it is true for men as well. Yeah, Uncle Eddie, sorry.
Yes, generally, men, it's always prostate. And generally, they look where they find it to blood work. The same principle applies with the breast.
No, we don't typically find it through blood work. For men, it's just going to be knowing your body. Because you don't have much breast tissue, you'll be able to feel things a lot easier and see changes a lot easier. So that's basically, it's pretty rare in men, so we don't do that screening because the numbers of cases will be so low that it really wouldn't be justify the expense or the inconvenience of doing that. So it's just really important for men to pay attention to your chest and know that though rare, it's possible. So if you see a lump, get it checked out. Yes.
I was like, 20 years ago, I found a pea-sized lump on my right breast, and I went to, fortunately Dr. Perry was alive then, I went to him. He tried to aspirate it in the office, but it was solid, so he said I had to have surgery to remove it. So he removed the tumor. I don't remember how large he said it was, but when they biopsied it, it was benign, thank the Lord. But is that common to have tumors and they are solid? Or he said had it been, I guess, had he been able to aspirate it, he would have known it was benign then, so I wouldn't have to have the surgery. But, and like I said, it's 20 years ago, and I have not had one since. But is that common to have tumors?
Yes, it is very common to have benign tumors in our breast. The most common tumor we see is called a fibroadenoma. We typically see those in the more younger women, but we do occasionally see them in postmenopausal women as well. But yes, you can get all kind of benign things in your breast. From calcifications to masses, distortions, it can all be benign, but a lot of times we won't know until we do a biopsy. Thankfully, in the 20 years, we've really advanced, so you wouldn't be getting a blind biopsy in Dr. Perry's office these days. Okay, you would come to a breast center and we would take care of you and make that experience a lot easier on you. So yes, and we might have been able to tell then, you know, with advanced imaging, and you might not have had to have surgery, but I'm glad that you took care of it just in case it would have been something. So yeah. Anybody else? Elder Smith? I'm sorry.
Bradley, this has been informative. I think we need to have you come back. Really.
Amen.
Absolutely. Go ahead. Give God a praise. We need to have you come back. When you were talking, I took this note about bias in health care. We need you to come back and educate us with statistics. I'm talking about line upon line. We need to know this because, like you said, we got to take control for our own selves.
We do. We absolutely do.
We want you to come back.
Yes, sir. Oh, I appreciate that. That's a compliment. Yes, sir. Yes, sir.
I do have one more question. Are they actually making any advances in the technology as far as curing
Treatments?
these cancers?
Yeah, there's actually an exciting one that's kind of on the cusp, and there's more like research studies. So certain women, if you qualify, you can be enrolled into these research studies for your treatment. And one of them is immunotherapy, which I'm finding really exciting. So I'm excited to see how that comes to fruition, and that's where we can program the immune system, which typically fights our battles for us, colds and things like that. But they're figuring out a way for certain cancers to turn your immune system on the cancer and specifically target. So the problem with chemo is that it not only can kill your cancer, it can kill a lot of your good cells. So chemotherapy targets rapidly turning over cells, rapid growth. Cancer has very rapid growth, so it targets cancer, but there are other cells in your body that have rapid growth. For instance, your hair follicles, and that's why women lose their hair. Your gut cells turn over rapidly, and that's why you can get a lot of nausea, a lot of gastrointestinal issues. And so, you know, that's one of the main problems with chemotherapy is that we can't necessarily target. We have to throw the kitchen sink at it, and it'll kill that cancer, but it'll also cause a bit of damage in your body that you'll have to, you know, work back from. But with immunotherapy, that collateral damage has been reduced or eliminated, and they're very able to target it. So I'm excited to see what comes of that one. Yes, Sister June. So the radiation is very localized, but again, it does have deleterious effects. So they try to keep the cone area within the breast tissue, but behind your chest wall, you have a heart, you have lungs. And so back in the day before they got really good and understand, you would have people that could develop pulmonary fibrosis or scarring of the lining of the heart or myocarditis. But nowadays they've really fine-tuned the dosages that they give you, and they recognize that we can still treat it with a much smaller dose. So we're really not seeing those types of deleterious effects from radiation as we did in the past. But it is something that they do have concern for. Say, for instance, a lot of women can develop a cancer twice in the same breast. If you've had radiation once, they won't do it again.
because that tissue just can't take anymore. But they are, slowly over the years fine-tuning that and shrinking down the area so that really just that breast tissue is what's affected. But back in the day, they had something called chest mantle radiation. So if you had lymphoma in your chest and you got radiation to your chest, those women have a much higher risk of getting breast cancer because that radiation, a very strong beam that was used to treat lymphoma inside of their chest, also went through their breast. And so those women get screened early as well. They don't really treat it the same as they did back in the day, so we don't see it as much. But yeah, radiation definitely in high doses causes cancer. But it's also, we figured out a way for it to, we use radiation to take pictures, microdoses, and we use radiation to treat cancer as well. And so it has its benefits, but you definitely have to be really careful. Looks like that's all. Well, I want to thank everybody for coming. This has been great. Exciting. And I hope that you learned something and that you can tell your friend, tell a family member, and save some lives. Thank you.